lovely introduction. It's such a pleasure being here. Sally, you know, I'm also very humbled being here because there's such fabulous work on early development and intervention in autism going on. And I feel like I'm learning so much just getting a chance to meet a number of the people here. It occurs to me the last time I was at a microphone, it was like to sing to my daughter at her bat mitzvah a month ago. But you're fortunate to get like the non-musical version of this presentation. This evening, I'll be talking a little bit about our work with infants at increased risk of autism and what we're learning about our early detection and diagnosis of autism. I'll start by talking a little bit about sort of progress that we're making sort of in the field and how far we need to go. What are we learning from prospective research with infants at increased risk, both from our own Canadian study as well as the number of studies that Sally alluded to, including Sally and her colleagues' work here, which is really leading the field in terms of understanding how behavioral differences relate to later observations and later manifestations of autism. And I'll also talk a little bit about implications for clinical practice. AJ actually asked me earlier today, you know, what's one of the most, you know, what's sort of the important next step for this field? And I think sort of the first reaction is the advancing the science and, you know, incorporating, for instance, biological measures into sort of early detection, because that's one of the real advantages of being able to do prospective research with infants at risk, that we're actually sort of working with real live kids that we can learn from and offer something to directly. But clearly there are some really important clinical issues that we need to push forward. One is intervention, because there's a lot at stake for these families. And another unique advantage of working with at-risk infants rather than just looking back through home video or asking parents to talk about their kids is that, you know, there's a real live infant and a real live family who are grappling with these concerns, and one can offer meaningful intervention. And again, Sally Rogers in particular and the Mind Institute group in general has really led the field in sort of helping us think about what we can offer that's meaningful for these families. I think another really important thing we need to work on is just how are we going to translate all of this into clinical practice? I have to say that, you know, there's a lot of, the uptake of autism screening into family physician and pediatrician's office has been pretty modest. There's still a lot of pushback, sort of the notion of sort of incorporating sort of formal early detection strategies into healthcare. You know, physicians are concerned about, you know, the false positive. They're concerned they don't have anywhere to send the kids once they identify them. You know, there's a long way we need to go in terms of sort of bridging what we're learning sort of in our research labs to what's actually happening in community practice. And as we're learning about what children with autism look like at 12 months or 15 months, you know, physicians are still struggling with identifying signs in some 3- and 4-year-olds. So, you know, we'll talk about early signs, but I'll try to put it into the context of sort of the health system and sort of, you know, because we really do need to have a multi-pronged approach if we're going to accomplish the goal of earlier diagnosis for children across the spectrum. So where are we at in terms of autism spectrum disorders? I mean, this will be obvious to all of you, but I think it's worth taking stock of our current understanding because I think it's relevant both in terms of our research design and it's just sort of how we make sense of some of the early detection data. So clearly autism is a heterogeneous and multifaceted condition. You know, that has a profound influence on the lives of people with autism as well as their extended families. You know, this is not an uncommon condition, and the children, in a sense, who've sort of joined the spectrum over the past 10 to 20 years are the children with, you know, who have less classic presentations. You know, it's encouraging because they include the more able children in terms of their language and cognitive development, perhaps children with kind of less severe symptom manifestations. But we need to recognize that diversity among the older people with autism that we know likely has implications for what we might expect to see early in life. And this whole line of research has been incredibly humbling. You know, I think a lot of us went into this field thinking, well, if we just look for the right things and we just pay careful attention enough, we're going to be diagnosing all children by the time they're 12 or 15 months. And in fact, often what we're seeing is the children that are seared into our memory are the children who have these sort of dramatic presentations really early in life. But of course, as one follows these high-risk infants, one recognizes there's lots of children with autism that are sort of flying under our radar as well. And in a way, the bigger challenge is making sure that we're picking up on children across the full range of the spectrum, rather than just sort of playing this, kind of have this effort to see who can identify a case of autism at the earliest age. Well, I can diagnose at 15 months. Well, I can diagnose at 12 months. But we're missing like a large proportion of those children if we get really stuck on just identifying the earliest possible signs. We're recognizing that genetics and genomics now play a very central role, but we also are, again, sort of humble that there's a lot that we don't know about the causes of autism. And certainly research, back to the early twin studies suggests that, if the concordance among identical twins is less than 100%, there's probably more going on. And just in speaking to David Emerald earlier today, I think an important shift in the field is that people with sort of different ideas and different hypotheses about the causes of autism are welcome at the table now. And there's a very healthy respect for kind of different models of autism, and a recognition that the complexity that we see clinically probably translates ideologically as well. And it's hard, and it's unlikely that there are children with just, that the majority of children have purely genetic or purely environmental. It's probably a complex kind of variation in factors, and it probably differs between child and child. We also recognize now that early intervention markedly improves outcomes, and I think there's a lot of exciting work, again, a very substantial amount of it occurring at the Mind Institute, thinking about ways of intervening early enough to actually sort of change the course, to perhaps even prevent some of the disability that might be associated with autism. I think we also have to take stock of why we do this research. And the reality is, when one speaks to parents, we're sort of meeting them where they've been for years in recognizing the early signs in the first year, the first 18 months. But when one hears the stories of these parents, often they've been to a number of so-called professionals, they've been reassured, he's a boy, he's your first, why don't we sort of wait and see? And invariably, there's been this extended period of time where parents are trying to get someone to listen, and even sort of seeing multiple specialists before the children are diagnosed. And although I think anecdotally, clinical programs are seeing more and more children being referred at 18 months or 2 years, and more early diagnoses are being made, the reality is that the median age of diagnosis, as I'll review in a moment, remains kind of around the age of 3.5 or 4. So there are still lots of children that are missing out entirely on preschool intervention, and we have a long way to go. And the reality is that this research is really all about a respectful and compassionate response to the concerns that parents have had for years, and starting to close the gap between when parents become aware of these early differences and when the children are actually diagnosed. Clearly, the motivation is getting children into effective and syndrome-specific interventions to actually change their outcomes. And then there is sort of the not-so-minor issue of the fact that autism can recur in a family, and families can be informed, if only to sort of pay that much more attention to the development of their younger children to provide support at an earlier stage. So as I mentioned, I think we have to be quite modest about the progress that we've made around age of diagnosis. And although some studies, particularly in the UK, suggest that the age has sort of drifted down somewhat, and again, anecdotally, the sense is that we're seeing more and more younger children. Data from, that was published as recently as a few years ago from children born in 2002, the median age of diagnosis across the CDC, Autism Developmental Disabilities Monitoring Network, was between 4 and 5 years old. And that's very sobering. There is, coming from Canada, there's sort of relatively limited research done in that area. One of the important studies is something that Eric von Bahn, who's a guest at the Mind right now, has been working on. It's a national longitudinal study of autism where children are being recruited at the point of diagnosis in several cities across Canada. And the bottom line is our average age of diagnosis is very similar to what we see in the States. We're finding median rates of a median age of about 3.5, but that's in a study that only children under the age of 5 at the time of diagnosis are recruited. So if one considers the subgroup who are probably going to be diagnosed past the age of 5, we're probably at that 4 to 5 point that many US centers are at. I'll tell you a little bit about a study that we've recently completed in Alberta, kind of a very crude study in a way where we linked pregnancy and birth records to diagnostic reports, at least based on physician billing records. We identified sort of a prevalence of roughly 5 in 1,000, which, to be honest, probably suggests that we're under-identifying based on that strategy. But most importantly, although we've improved in terms of our age of first identification, our starting point was pretty dismal. And again, as recently as the early 2000s, our average age of diagnosis was around the age of 4. So again, there is this significant gap between when we're starting to see the earliest signs and what's actually happening in the community. And the research that I'm going to tell you about, I hope, along with the other studies, will continue to inform about the early signs of autism, but it's not going to be the whole solution. So we need to recognize sensitive and specific early risk markers. We need to sort of translate this into an assessment process that can be integrated into well child care, that's time efficient, that's experienced positively by both the children and the family, and kind of builds on a system that somehow can support the children who are with ASD who are flagged, but it can also support the children who don't have ASD but have other developmental issues who might be flagged through this sort of kind of early screening process. Again, these points here are not minor. The physicians I speak to who are really resistant to try ASD screening in their office, usually the reason that they give is they have a hard time accessing a diagnosis for the children they're really convinced about. So they're a bit reluctant to sort of take a risk for by screening children that they don't immediately have concerns about. And the whole issue of sort of the capacity of the health system to provide specialized assessments and treatment to children who are being identified through a more comprehensive early identification strategy is something we need to address. At the same time, we're sort of moving this information out into the community. So those caveats aside, I'll talk a little bit about what we're learning through prospective research with infants at risk of autism. I think it's important to acknowledge that this research approach is not unique to autism, and in fact was really, there's a lot of work that's been done in schizophrenia, in ADHD, in looking at sort of family members of individuals who have the condition. I think one of the unique opportunities within autism is that it is a relatively early onset and early diagnosed condition. So whereas in schizophrenia, one needs to follow at-risk people kind of into late adolescence or early adulthood, in autism, one can work from the earliest stages of infancy or even prenatally, and within 3 years to be pretty confident about which of the children actually have the diagnosis. And I'll just refer you in particular to Sally Rogers' really nice review of this area in 2009, both looking at the advantages of the research design and also kind of what we're learning from this body of work. So what are we learning about early signs of ASD from this line of research? So some of the data that I'll focus on today comes from our Canadian study, which includes 4 sites in Halifax, Hamilton, Toronto, and in Edmonton. And I noticed there's no snow on the ground in the Glenrose slides, so I think there's like 1 week in July that you can sort of safely take a photo like this and sort of have it look that way. So this is a multi-site study. My co-principal investigator is Susan Bryson, who's a psychologist based at Dalhousie University. We've been working with this cohort now, actually, starting in 1999. We were recently funded to follow these kids to the age of 8. So this has actually become sort of, kind of a long-term effort. Currently, we have about 440 families who have a child with autism where we've had the opportunity to follow the younger sibling, as well as 180 families with no family history of autism, and who've provided us very generously with their time the opportunity to follow their infants as well. These children are assessed starting at the age of 6 months, initially at 3-month intervals until the age of 18 months, then at 2, and then at age of 3. And at the age of 3, the children are seen by an experienced clinician who completes the ADI and the ADOS. We very purposely kind of keep them in the dark initially, so they don't know if the children they're seeing are a sibling of a child with autism or are coming from a family where there's no family history. They don't review the sort of the file, or we don't kind of talk about sort of the concerns that came before, just so that that clinician can give an independent opinion about whether the child has autism that's not related to sort of what the previous concerns were. And then, and then that situation is managed clinically. And of course, the clinician wouldn't give feedback to the family without sort of understanding the earlier history, but they do make a clinical judgment sort of based on the information sort of that's just at the age of 3. And the measures that I'll talk about today include an observational measure of early signs, as well as symptoms measured by the Autism Diagnostic Observation Schedule, measures of language and cognitive development, including the Mullen Scales of Early Learning, assessment of visual attention, which comes from an experimental task that was kind of adapted by Susan Bryson for this infant SIB population, as well as kind of a couple of the items from our infant observational scale. And then we've also looked at infant temperament by parent report using the Rothbard questionnaires. It's interesting that this comment is something that we kind of take for granted now, but until several years ago, I think that was still a bit contentious. Parents very consistently, when one goes to that literature, upwards of 50% of parents will recall developmental differences in the first year, and yet there was a sense that, for most children, there may not be sort of obvious signs. But I think the bottom line is the observations that have been made through this infant research have been very consistent with what parents have described for many years, and really sort of reinforces the importance of taking parents' concerns very seriously. So from our first publication from this study, we followed 150 of the high-risk infants, including a relatively small number to the age of 24 months. And what we reported at the time was that there were key observations at 12 months that were associated, let me get rid of this, with autism, which included kind of early aspects of social communicative behavior, eye gaze, social smiling, sharing of positive emotion during an interaction, kind of orienting to name, which Sally and the group have reported on specifically in their cohort, sensory-oriented behaviors, which I'll talk about in more detail, and then sort of other signs that are not sort of part of the kind of the diagnostic criteria for autism, but have been recognized as being significant issues among children with autism and seem to have early correlates among at-risk infants. So atypical regulation of visual attention and also emotion, and both in terms of lack of sharing of positive affect and sort of difficulties regulating negative emotion as well. And then interestingly, atypical patterns of language and cognitive development that I think were somewhat unanticipated sort of in these high-risk cohorts, and that I'll speak about in more detail. And then I think the thing that really surprised a lot of us was, we sort of went into this research recognizing that some of the cardinal features of autism, like eye gaze and social smiling, are well established in the first few months of life. So if we could only bring in these infants who would later develop autism, that it should be sort of obvious to us by the time the children were 4 to 6 months of age. That it hasn't sort of panned out that way. And it's not to say that there aren't that there isn't sort of features or developmental differences that might be informative at 6 months. But often in seeing 6-month-olds, even the ones who go on to develop autism, the manifestations are much more subtle than one might have anticipated. So just to briefly describe our observational schedule, which we really developed for the purpose of trying to track these early signs in the first 18 months of life, recognizing that there are a number of excellent measures for different aspects of the autism phenotype, but it was helpful to have a measure that would kind of cover the broader range and to try to, at least by design, to try to cover the age range that one would be interested in looking at early features. So this observational scale is administered in the context of kind of a comfortable, interactive a series of activities. I'll show you some video for those of you who haven't seen this, just to give you a sense. And it covers sort of aspects of the early autism phenotype that many of you would think about in sort of pursuing early identification. So aspects of visual attention, so tracking objects across the visual field, disengagement, so essentially the ability to, once the child is oriented to something of interest, to be able to sort of unstick their attention and shift it over to a second toy or object of interest. Again, response to name, back and forth social babbling, other sort of kind of basic social behaviors like social smiling, anticipation as part of a game of peekaboo, sharing of positive affect, early play behavior, so imitation, sort of behavioral regulation, things like reactivity, how the children manage during transitions between activities, and then some of the atypical and repetitive behaviors, which I think prior to a lot of this high-risk research were typically regarded as manifestations that were more typical of somewhat older children. And I think that there were mixed opinions about whether one might see manifestations of repetitive interest in working with such a young population. So just to briefly summarize, as I said, there's sort of been a surprisingly, it's been a bit surprising that the children with autism haven't stood out more when we see them at 6 months, given that some of the things that we measure are typically present at 6 months and yet sort of so different in older children with autism. So things like sharing of positive affect and social referencing and atypical behaviors are, distinguish the high-risk group as a whole from the low-risk group. But within the high-risk group, the children who go on to develop an ASD versus the children who do not have an ASD when they're seen at the age of 3 are actually relatively similar in frequency. And the only difference that we've been able to find, at least on a group basis at this point, is motor control. Now, things like low tone, lack of postural stability. Clearly, these are, this is not an observation that's going to be specific to autism, and yet, it is of interest. I mean, it really reinforces the, motor concerns that are seen later in development in autism, and I think it just reinforces autism as a neurodevelopmental disorder that might have manifestations before sort of the more cardinal features. But there's an interesting shift between 6 months where there's so much similarity between the non-diagnosed high-risk infants and the diagnosed high-risk infants, to the age of 12 months, where there are many differences that stand out in terms of the frequency of atypical eye contact, lack of sharing of positive emotion, lack of social referencing, extreme reactivity, and then these sort of atypical motor and sensory behaviors, which, in a sizable minority are quite prominent. But it seems that the story may be even more complicated than that, and we've just started to look at sort of differences within the ASD group and whether that might map on to some of the early observations. And I'll return to this after, but essentially there are some of the features that are present regardless of the functional level of the child at the point of diagnosis at the age of 3. So, for instance, if we divide the children with autism based on their IQ level at 3, less than 70 versus, although okay, this is meant to be above 70. You can see that some of these features are quite robust, including the atypical behaviors, eye contact, and social interest and affect. And yet there are some of the features like imitation and reactivity that are quite frequently atypical among the lower IQ group, but where the higher IQ group are actually very similar to the non-diagnosed group. And again, it sort of speaks to this whole phenomenon of children sort of flying under our radar, and how just because we see some children who have more obvious symptoms of autism at 12 months, it doesn't imply that all children with autism will have obvious features at 12 months. So I will return to that point. So just to sort of briefly review, so that's kind of a bird's eye shot of sort of the features that we're seeing within our study. But I think there's a lot of convergence across these different high-risk cohorts. And I should say that that's true both of studies that follow younger infant siblings, but also true of studies that have screened in the population for early features like communication delay. Amy Weatherby at Florida State University has really led the field in this, screening with the infant-toddler checklist from the communication symbolic behavioral scales to identify sort of a broadly defined group of children with communication delays, and then looking at what discriminates children who go on to develop autism from children with other types of language and communication delays. And really what she's seen in that cohort is very similar to what's been observed in the children identified through these kind of sibling studies. So atypicalities in social communication. You know, again, reduced social smiling, atypical eye gaze, reduced early joint attention behaviors, and maybe at a gut level, and in terms of what's been most consistent across the studies, is sort of a reduced expression of kind of joyful emotion in interaction with others. And let me just illustrate this. So this is a 12-month-old girl who has an older sibling with autism, who's kind of Mullen score, so whose cognitive level is sort of kind of within the average range, whose parent actually doesn't have specific concerns at this stage, but you can kind of see, despite her interest in the activity, sort of how little sharing of positive emotion there is. Oops. So she's orienting, she's aware, but you know, you just don't get that facial, you don't get that sort of sharing of emotion through her facial expression. Play interests and behavior. And you know, of course, there's reduced imitation, there's reduced interest in social play, and, but one thing that's been really striking is sort of the repetitive interests in objects, including play materials, which again was not necessarily anticipated as being sort of such an early emerging feature, and yet has been identified by a number of groups, including a paper by Sally Ozanoff, just looking at repetitive actions with toys. And part of this is this sort of intense visual inspection of play materials, kind of looking at things from all angles, getting very focused on sort of kind of other sensory aspects of the toys. Just to illustrate this briefly, this is a little boy who actually doesn't have an older sibling with autism, but just has a very astute, has very astute parents who recognize that he wasn't making eye contact. And this is just a brief clip of how he explored his toys. So at first it sort of comes across as sort of typical sensory exploratory play. And yet you'll see he gets very focused, and you can see that his orienting to the toy isn't accompanied by orienting to his mom or kind of sharing of his interest in any way. And asking his mom, he could do this for up to 20 to 30 minutes at home unless she redirected him. Okay, I'm going to move on. Temperament has also been an interesting framework to think about some of these early features. And again, this is based on parent report. So there are kind of two dimensions that we've identified through our analysis of the temperament data. One is underreactivity. And Sally and I were actually speaking earlier today about some of the children who, in fact, do sort of present at 6 months as being sort of developmentally atypical. And some of the prominent features, just in chatting about those kids, are that real flatness, sort of that serious expression, lack of response, over-focus, and that's very much what parents are reporting on the Rothbard temperament questionnaires as well. This sort of being low on positive affect and sort of low on attention shifting, so getting sort of very fixated on sort of particular objects. And then there's another factor which we've kind of labeled as emotional regulation, which is less about sort of lack of positive affect and more about sort of elevation of negative affect. So these are the sort of irritable, difficult to console children that many parents of children with autism sort of kind of reflect back on the earliest months of infancy as being sort of very prominent features. And then also kind of difficulty with sort of maintaining attention. And interestingly, the underreactivity factor distinguishes the children who go on to a diagnosis of autism from other high-risk infants as well as low-risk infants, whereas problems with emotional regulation are observed, or at least reported by parents, across the entire high-risk group. So are particularly prominent among the children who are diagnosed, but issues of irritability and problems with attentional control are also reported by other parents within that high-risk group. And again, sort of speaks to sort of that broader expression, which it has a, certainly has a significant impact both on the children and the families, and I think also speaks to some of the challenges of disentangling sort of what's autism and what's other developmental differences early in life among this high-risk population. And then again, this surprising observation that some of these cardinal features, which if autism sort of onsets at the earliest stages of life, you would think would be present by the age of 6 months, and yet seem to be sort of kind of more of a later emerging pattern. Sally actually probably presented the most convincing argument of this in a paper that was published earlier this year, looking at social behavior observed and quantified during cognitive assessment. So finding reductions in directed gaze, directed vocalization, social smiling, and overall engagement over the period of time between 6 and 36 months, and really particularly between 6 and 18 months. Which kind of speaks to the whole issue of regression, because if you look at these graphs, the children with autism genuinely directed their gaze and have had sort of fewer directed vocalizations over that period of time. It's quite interesting that it's somewhat earlier than the regression that has been reported retrospectively, where the focus has been more on verbal language, and the dating of that regression has been really sort of kind of in the second year of life, often around 16 to 18 months. We've certainly seen this kind of regression on our behavioral observations as well, but I will kind of come back to the earlier point that it's not true for all of the children that go on to a diagnosis of ASD. And I think as our research sort of reaches that critical juncture where when there's enough children with ASD, we can start looking at individual differences and recognize that there may not be sort of one single pattern of development that identifies autism in all children. So in fact, we've looked at our scores on our infant observational measure between the ages of 6 and 18 months. And we've used a statistical method called semi-parametric group-based modeling, which essentially looks at whether there are groups of infants who have similar patterns of development on a particular measure. And here we've used the infant observational scale. And essentially what we found is that there are many infants who kind of start with kind of very little in terms of early behavioral signs of autism and sort of remain at that level. There's another group who kind of have a moderate level of sort of social communicative differences, but sort of remain very stable. And then there's this very dramatic group who are indistinguishable from that other middle group at the age of 6 months, but by the age of 12 and 18 months have really quite marked signs. Let me just illustrate that in a clip, just to give you a sense that although this isn't necessarily representative of all children with autism, that there can genuinely be children who, despite having severe symptoms of autism at the point of diagnosis, going back and seeing what they were like at 6 months, their social behavior is relatively typical. A little reminiscent of what that first little girl was like in terms of that lack of facial expression. And then here he just seems like a totally different kid. So here's at 24 months. So again, I mean, it's a quick snapshot, and it's obviously a limited sample of behavior, but the pretty dramatic differences between the ages of 6 and 24 months. It breaks your heart seeing this, but this is the sort of child that you could show to a pediatrician, and they'll recognize that there's something developmentally atypical about this child, and that one could watch for sort of these kinds of changes to be able to flag sort of children at risk. But however, there are many children with autism who don't fall into that sort of dramatically presenting category. And in fact, as it turns out, the majority of the children that we've diagnosed with ASD through our sample are in these sort of two stable groups of symptoms, which makes it a lot harder to kind of educate health professionals. And it's not like, it's not like the majority are in this low stable group, but there are kind of a fair number of children who are sort of in this moderate stable level of symptoms. And it won't surprise you that the children who have a more florid presentation tend to have more severe symptoms as well as more severe language and intellectual deficits by the age of 3. But again, that's sort of the minority of our sample. And just to give you a sense of what one of the higher functioning kids might look like between the age, between 6 months and the age of diagnosis, let me show you Ewan. So again, like a delightful, highly engaged 6-month-old. Making great eye contact, social smiling, and he'll do sort of a brief glance towards his mom and sort of really checking in and sort of that real sense of connectedness. Here he is at 12 months, just a little more serious, a little more kind of object focused, but not necessarily someone with sort of that you would pull out of a group of children as having a developmental disorder. He sort of disengages from that. So I have to say, this is a family who has 2 children with autism as well as 5 typically developing children. And at this stage, to be honest, even up to the age of 2, the family regards him as being much more similar to their typically developing children. And I have to say, showing that video to a group of pediatricians, I think what they're most struck by is how well he responds, and that's, that is a bit of a barrier. So here he is at 24 months. So again, he responds, but immediately when she stops, he looks away. I'll just show you a very brief clip at 36 months just to show you sort of at the point of diagnosis what he was like. again, I mean, so this is a little guy who, you know, has an IQ of 115 and average language skills, and actually sort of kind of fits, you know, if you had to make a diagnostic subtype, sort of is, you know, his presentation is consistent with Asperger's syndrome. Children with Asperger's rarely, you know, although among my wonderful colleagues here, I'm sure you are seeing kids regularly at an early age, you know, historically, typically don't get referred until the age of 8 or 9. And I think there's just not a lot of experience with diagnostic assessment in children with such subtle features. You know, reflecting back on sort of how he changes, you know, there are some consistent patterns in terms of the change in his facial affect and how object-oriented he is, and some of the lack of spontaneous social behavior. And yet he's a sort of child who could very easily fly under people's radar, particularly in the community. So, you know, bottom line is there are a number of behavioral features that distinguish children who go on, at least within this high-risk cohort, to a diagnosis of ASD from even other high-risk infants. But as I commented earlier, you know, it's not sort of universally the case. And again, if we divide up the children with ASD into the lower functioning group versus the higher functioning group in terms of IQ, many differences remain, but the magnitude of the differences are smaller. And there are some kind of specific markers that just don't apply to the higher functioning kids, like a lack of imitation, lack of extreme reactivity, and sort of some of the atypicalities in early visual attention. Similarly, I'll just comment a little bit about some observations on early language and intellectual trajectories. In our kind of first case series of children with ASD that were identified through this high-risk cohort, my colleague Susan Bryson and a number of us sort of remarked on, you know, some of the dramatic changes in the standard scores among some of those children. You can see that there's actually quite a substantial subgroup, at least out of this small number of, you know, 9 children, who at the age of 12 months actually had average cognitive scores, and yet by the age of 36 months, you know, had dropped to a standard score, you know, below 3 standard deviations below the mean. And there was this sort of steady decrease in standard scores between 1 year and 3 years. Using a similar statistical approach, I mean, there is genuinely a subgroup of children within this high-risk cohort that one can pull out empirically on the basis of having dropping standard scores on the Mullen scales. And, you know, not surprisingly, the vast majority of those children have an autism spectrum disorder at the age of 3. There's something that's very atypical about this sort of dramatic change in standard scores. And yet, like with the dramatic pattern of AOC changes, it's really a minority of the children with autism, even the lower functioning children with autism, who are necessarily in this category. And the majority of children with autism still have kind of a relatively stable cognitive trajectory. And again, it just sort of speaks to the heterogeneity and the fact that there may be a subgroup of children, at least within these high-risk cohorts, that are sort of easier to identify at an earlier stage than others. So I think this observation about behavioral change as well as change in language and cognitive development has sort of kind of stimulated a lot of discussion about sort of the relationship to regression as we sort of currently understand it. And of course, as we currently understand it is really, for the most part, parents reflecting back on sort of the child's earlier development. Although there's home videotape studies as well that have kind of substantiated the phenomenon in the sense that children who are reported as having a regression do show a different pattern of development and behavioral change between the age of 1 year and 2 years. But both the data I've shown today as well as the graphs from Sally's study, I think they really speak to that although there is you know, there is an apparent regression among some of the children with autism in terms of behavioral change. It's not quite as discrete as we might have anticipated on the basis of people looking back. That, you know, you see a change from 6 to 12 months, but you see a change again from 12 to 18 and even 18 to 24. It seems to be more of a gradual and continuous process. And also it seems to occur a bit earlier than we've sort of kind of come to believe based on retrospective research. The fact that there's sort of this kind of spectrum of developmental trajectories suggests that regression may be sort of the tip of the iceberg or kind of the extreme of a continuum of developmental trajectories. And the truth is, even though those children who have a dramatic drop in standard scores on the Mullen, most of those children are actually continuing to show some increase in the raw scores. And it's really just that they're sort of falling away from their growth curve on intellectual and language development. And people have sort of used the word plateauing in the sense to just describe that, you know, there isn't this sort of steady pattern of development, but rather this kind of almost kind of slowing of acquisition of new skills. And, you know, through these longitudinal studies, I think we're not there yet, but hopefully we can start to disentangle the relationships between the emergence of early social impairments of autism and changes in pattern in language and language and cognitive development, and understand sort of the interrelationships between the two. You know, clearly having sort of change in intellectual development may interfere with your kind of social development, but yet sort of being kind of not orienting to the social world is going to also affect spontaneous opportunities for learning as well. So what are the clinical implications? So our consortium group have really grappled with sort of what to advise clinicians, and how do we translate these observations about early signs into kind of diagnostic clinics. And I think we've just acknowledged that this is new territory for all of us. And I mean, you can imagine, you know, having people like Sally Rogers and Sally Ozanoff and Wendy Stone and, you know, leaders in the field, and you know, realizing that we're all kind of scratching our heads and realizing that we just haven't seen a lot of 12-month-olds and 15-month-olds who've been referred to the diagnostic clinic. So it is somewhat uncharted territory in terms of knowing how to kind of operationalize the criteria for children at an earlier stage of development, how to manage some of that uncertainty about sort of what the developmental course will hold, and just recognizing that there just isn't a strong evidence base in terms of knowing what the stability of these diagnoses might be that might be applied at such an early stage. We also recognize that it's a bit of a double-edged sword clinically working with a high-risk population, because these are children who are at increased risk of autism, but they're also at increased risk of other developmental disorders, including language delay. And we've just recognized that it may be difficult to disentangle the developmental differences associated with different diagnoses at such an early stage. It doesn't help that a lot of the features that we've kind of focused on based on our diagnostic work with older children require a certain developmental level. So if you're focusing on early kind of, you know, triadic attention, for instance, you know, kind of, you know, sort of, you know, joint attention to sort of kind of direct someone's attention to an object of interest and kind of shifting attention back and forth. I mean, one doesn't expect to see that kind of behavior, you know, until sort of 9 to 12 months. So if you're seeing a 15-month-old who's developmentally delayed and at a 6 or 7-month stage, it becomes difficult to know whether the absence of those behaviors is due to autism or due to developmental delay. And we kind of need sort of better ways of sort of thinking through and making those distinctions, you know, if those exist. And again, there are somewhat fuzzy boundaries sort of among these diagnostic groups. But I think that we would agree that there's certainly a number of lessons that we've learned, even from this kind of brief, relatively brief experience working with very young infants with early signs of autism, including infants that we've had a chance to follow over time and be more confident about their ultimate diagnosis. It's been very humbling. I mean, we recognize that there's a lot that we don't know, but that there's still a lot that we can offer. It certainly reinforces that autism is a developmental disorder. Early signs have continuity with later manifestations, but there's probably as much diversity early in development as we see later in development. It certainly does reinforce that we need to listen to parents, and that there's been, you know, really remarkable consistency with what we've observed during infancy and what parents have kind of described in terms of lack of positive affect, thank you, that behavioral sort of dysregulation, but also I think some features, kind of differences in visual attention that may not have kind of come up as spontaneously sort of in retrospective research. I think we need to sort of make the caveat that that younger siblings are not necessarily going to be representative of all individuals with autism. And I think we also have to recognize that the experience for a family of having a child with autism and then sort of having to agonize over the development of their younger sibling may lead to sort of differences in reporting that we might not expect. It might lead to parents being sort of very sensitive to some of the early signs, or even to some behaviors that may overlap with typical development. Or it may lead to some families kind of sort of focusing on the contrast between the older child and the younger child. And I've spoken to a number of researchers who work with these this kind of group of families who, it's almost a bit of a paradox. The parents are incredibly sensitive, incredibly aware of their child's early development, and yet if their older child is more severely affected, it's hard to sort of interpret some of the differences sort of along the autism spectrum, and it comes up very frequently. I think it certainly reinforces the importance of caution in ruling out an autism spectrum disorder at an early age, especially among higher functioning children. And that's probably a really important educational point for clinicians. And I think that we are now joining parents in terms of living with uncertainty, sort of recognizing that our clinical decisions can't be sort of tied up in clinical diagnoses, and that in fact, if we're really going to make a difference, we're going to need to initiate interventions that are targeted to specific functional concerns, not after the diagnostic process, but actually concurrent to it. I don't have a slide on it, but clearly the Early Start Denver model and the research related to it have been extremely influential in the field in recognizing that intervention for children as young as 18 months can make a remarkable difference in terms of accelerating early development. And I think has been a bit of, and I tell my clinical colleagues that it's been a bit of a game changer in terms of having substantial clinical trial evidence that intervention at that stage can affect outcomes. And I think it's already starting to influence public policy. As research moves to younger and younger groups of children, I think it's really important that we sort of document the gains that children can make through these types of interventions, because it will sort of help kind of policy and health decision makers incorporate these evidence-based approaches into sort of available programs. Our group has kind of adapted and developed an intervention program that's targeted to infants who are showing early signs based on observations during our observational scale. This is an intervention that's been studied in children between the ages of 12 and 23 months. And is really based on the principles of pivotal response training, which is a kind of an applied behavioral analysis approach to early intervention based on behavioral teaching principles, but has tried to incorporate kind of more of a developmental framework with a focus on the infant-parent relationship, the focus on emotion sharing, as well as early communication. My colleagues, Susan Bryson and Jessica Bryan, have completed an initial evaluation of this intervention in a group of 8 children, sort of looking at their individual response, and has found some promising improvements sort of among those children in terms of reductions in symptoms and improvements in language and positive affect, and sort of really kind of following now in Sally's footsteps in terms of launching a randomized controlled trial in the new year to see sort of how these effects sort of pan out sort of within that rigorous design. Other new directions, which a number of us have had a chance to talk about today. As I commented, the prospective research really provides a unique opportunity to look both at biological as well as behavioral markers and whether they may be predictive, and of course whether biology, for instance genetics, actually tells us something about the underlying mechanism for developmental differences in autism. So with a group of colleagues in Canada through a new research network called NeuroDevNet, we're actually collecting genetic information on these infant siblings to see whether children with kind of specific genetic differences might have different patterns of development, or whether kind of having a genetic marker may actually identify which of those infants are going to go on to develop autism or some other developmental outcome. This kind of logo here, the Ontario Mental Health Foundation, just is there to remind me to mention that I have a colleague who's a psychologist who works in infant development programs and infant mental health programs, who's now using our infant observational measure to look at these other at-risk populations. And it won't surprise you that there are a number of children with developmental delays or sort of early mental health issues like around attachment who have a number of these social differences that we're measuring on the observational scale. And a number of us were commenting earlier that one of the limitations of the infant sibling cohort, the infant sibling group, is that although one sees a range of development, including developmental disorder, it doesn't quite cover the landscape. And in particular, one doesn't see many children with intellectual disability or global delay in the absence of autism. So in terms of thinking about how to translate these observations into clinical practice, I think we need to sort of have answers to those questions. It's not only about distinguishing autism from typical development, but it's about distinguishing autism from other developmental conditions, so we know what types of assessments and supports to offer to children, or at least to sort of recognize that if it doesn't make those kind of distinctions in a straightforward way, that there needs to be another level of assessment before we sort of go straight to the autism clinic. The Baby Sibling Research Consortium, which Sally alluded to earlier, it has really been, I think it's been a very rewarding experience working with other colleagues who are grappling with similar clinical issues and have similar research interests, and being able to take advantage of the larger number of families to look at, kind of very important kinds of questions, like what are the rates of autism among these families? Are there sort of biological features that we're all looking at, like changes in head circumference, that might be predictive? And I think a growing interest in sort of pooling across studies to look at EEG and ERP, to perhaps look at medical issues. They're working with a diverse group of colleagues with large samples provides an opportunity to explore questions that would be hard for us to do individually. I included the Children's Hospital in Boston just to allude to some work that I did with Chuck Nelson around sort of training on ERP. And there's a growing number of groups that are looking at EEG and evoked responses as a way of looking at information processing and brain response. Again, both looking at sort of what might be the neural mechanisms for later social differences, but also perhaps sort of as an early marker that might be predictive. And then finally, just our recently funded work to follow this cohort to the age of 8. It's taken so long just to follow them to the age of 3, and we realize, though, that we're just at the beginning of the story, and there are still some children where we're not 100% certain about sort of kind of what their ultimate status would be, even though they don't quite meet criteria for autism right now. We recognize that there are a lot of important issues among individuals with autism that emerge somewhat later in life. Mental health issues, kind of learning issues, and that whole interface between the broader phenotype and autism is something that's difficult to disentangle at 3, but hopefully we'll learn more sort of as we follow the children along. So just to briefly summarize, I think collectively, prospective studies of autism with high-risk infants have been informative, not only for kind of specific early behavioral markers, but for patterns of development that are quite distinctive and maybe quite informative for anticipating which children will develop autism. I think that we need to recognize that we can only go so far with our observational data and our videos, and it's informative, but we have a lot of work to do to translate that information into better kind of health practice, and also work with clinicians to incorporate these kinds of observations into their work with young families. Progress in early detection must be accompanied by parallel advances in early intervention. It's really unethical to be identifying these early signs if we're not making some effort to provide something meaningful and effective. And I do think that over the next several years, there's promise of integrating both our observations as well as biological markers in terms of refining our predictions and better understanding the mechanisms underlying differences in autism. Of course, this is the work of many individuals, particularly my co-principal investigator, Susan Bryson, Isabel Smith, Wendy Roberts, and Jessica Bryan in Toronto, Peter Zatmari in Hamilton at McMaster. I just acknowledge our funders and, of course, the many wonderful children and families who've been so committed and invested in this work. So thank you.
That was a wonderful talk. So I would like to open it up to the audience for questions. I'm going to take this microphone around so that everyone is able to hear the question. So if you've got one, just raise your hand and I'll bring it to you. Anybody want to kick off? Okay, Peter Mundy.
It was a great talk, Lonnie.
Thanks, Peter.
You know, a couple times you mentioned that when you were using responding measures, you weren't getting a lot of discrimination unless the child looked like they were affected by intellectual and developmental disabilities. But the spontaneous, the self-initiated measures seem to give you a little bit more traction in identification. Just looking at your scale there, is it possible to separate out all the initiating behaviors and the responding behaviors and see if that gives you a little bit more insight, not insight, power of identification?
You know, it's a great question, and it's like one of those things, like if we could only go back and sort of design it in a slightly different way. When we've talked about adding, you know, I think we don't have enough about sort of social initiation, and we don't have, you know, again, sort of, you know, retrospective vision is 2020, you know, having something like the ESCS as a way of kind of quantifying those kind of initiating and responding behaviors in a way that we could sort of go back to the tapes later rather than having to, you know, rather than having to do it online. When we initially developed the observational scale, we sort of designed it to be something that could be coded sort of as it was administered, and thinking about sort of how it might be used sort of in a clinical setting. And I don't think that we were sort of as oriented to the fact that there might be a disconnect between responding and initiating as we are now. So I think it's an important point. I suspect that we could go back to the videos and try to quantify it. But yet I'm aware there are certainly other infant SIB research studies that are using sort of standardized measures like the ESCS at an early stage. And I think that will provide, I think, sort of a pretty powerful test of that hypothesis. But you know, I mean, so it's an interesting observation, but I think we'll have to do, at the very least, sort of a secondary analysis of sort of the kind of the video data.
So you talked a bit about there are individuals whose siblings later go on to develop autism, and then there's another group of individuals whose siblings don't later go on to develop autism. Do you think these two groups are representative of clinically significant subgroups in autism? Do you think they might have different underlying etiologies, for instance, or might respond to treatment differently?
Yeah, I mean, they're great questions, and I think it sort of partly speaks to the importance of working with other high-risk and ultimately sort of low-risk populations to look at whether the relationships among sort of these early observations and later outcomes is similar across populations. I mean, that being said, I mean, I think we do have some information from other family studies to go by. For instance, comparing the clinical characteristics of children from kind of single incidence families to multiple incidence families. And you know, in the genetic studies, they're relatively similar populations in terms of IQ level and symptom severity and so on. The initial work with the copy number variants, sort of rare genetic variants, suggested that there may be sort of more of these variants among sort of simplex, kind of single incidence and multiple incidence families, sort of reflecting that these may be sort of kind of sporadic syndromic cases of autism. But in fact, the data that's come out over the past year suggests that, you know, that one may see a similar number of these copy number variants in this multiplex as in the simplex. So I think on one hand, one can't make assumptions that the relationships and just sort of the profile of early symptoms are going to be the same in all groups of children with autism. And yet, you know, at least what we know about the single incidence versus, you know, children with autism from single versus multiple incidence families, there doesn't seem to be sort of dramatic differences in sort of the kind of distribution of symptoms and kind of intellectual or language level.
I was just wondering, when they saw the siblings that also exhibited autistic symptoms later in life, did they also do studies of the parents, and did parents fall on some spectrum of kind of an autism, and as opposed to the ones that had only a one incidence, maybe neither parent or didn't have any other family history?
Yeah. So great question. So we didn't specifically collect broader phenotype data, but in fact, Sally with AJ actually sort of recently reported a paper kind of looking at the, you know, whether kind of traits that have been sort of described as being part of a broader autism phenotype might somehow differ between families of where the younger sibling go on to a diagnosis versus those that don't. I mean, I wonder if you want to comment on that paper. Or either AJ or Sally, yeah.
Yeah, the paper looked at, it was using the SRS and looking at family affectedness, and really overall family affectedness did not predict which children would go on to develop autism. So it wasn't that a more affected older sibling would be like more predictive of younger children developing it. Yeah, so that's that. Can I ask a question too?
Yeah.
Okay,
so
specifically your temperament data, looking
Yes.
at that. So those children who are underreactive versus kind of that overreactive groups, did those line up at all with kind of developmental trajectories such that more affected children tended to be more underreactive when they were younger?
So I think the simple answer is yes, although I don't think we've sort of analyzed it sufficiently formally. I mean, we actually, Nancy Garan, who's currently on faculty but was a postdoctoral fellow working with Susan, working on the data, did actually find that that sort of underreactive group did tend to be sort of on that kind of developmental trajectory of sort of declining standard scores on the intellectual and language skills. And yet for the sort of the overreactive group, there was a lot more variation. It didn't map neatly onto sort of any profile, and one saw it sort of both kind of among kind of lower functioning kids, higher functioning kids. And of course, one can see sort of and parents talk about this as well, sort of a combination of the dimensions in a sense. Children who are sort of both kind of have flat affect, but also sort of periods of extreme irritability. But in terms of the particular analytic approach, it was really sort of identifying distinct groups. And that group that was underreactive were sort of among the lower functioning by the age of 3.
Yeah, that's a great topic.
Thank you.
How can we get your PowerPoint?
Well, maybe I will also turn that question over to Sally, but I think it's actually it's posted, eh? Yeah.
All the talks from the Distinguished Lecture Series are eventually posted on the Mind Institute website. Dan, what would be the timing in general for these to be available?
This one's going to be available by Friday.
Wow.
By Friday.
Wow.
And all the ones that have ever been held here, in fact, are available and get downloaded all the time. So 2 days. Yeah, give them
Fantastic.
to. Great. Any other questions that people would like to ask Dr. Zwigenbaum before we wrap up? Okay, then. Thank you all very much for coming. Thank you.
Thank you.
The UC Davis Mind Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.
Lovely introduction. It's such a pleasure being here. Sally, you know, I'm also very humbled being here because there's such fabulous work on early development and intervention in autism going on. And I feel like I'm learning so much just getting a chance to meet a number of the people here. It occurs to me the last time I was at a microphone, it was like to sing to my daughter at her bat mitzvah a month ago. But you're fortunate to get like the non-musical version of this presentation. This evening, I'll be talking a little bit about our work with infants at increased risk of autism and what we're learning about our early detection and diagnosis of autism. I'll start by talking a little bit about sort of progress that we're making sort of in the field and how far we need to go. What are we learning from prospective research with infants at increased risk, both from our own Canadian study as well as the number of studies that Sally alluded to, including Sally and her colleagues' work here, which is really leading the field in terms of understanding how behavioral differences relate to later observations and later manifestations of autism. And I'll also talk a little bit about implications for clinical practice in terms of autism spectrum disorders. I mean, this will be obvious to all of you, but I think it's worth taking stock of our current understanding because I think it's relevant both in terms of our research design and it's just sort of how we make sense of some of the early detection data. So clearly autism is a heterogeneous and multifaceted condition that has a profound influence on the lives of people with autism as well as their extended families. This is not an uncommon condition, and the children, in a sense, who've sort of joined the spectrum over the past 10 to 20 years are the children with, who have less classic presentations. It's encouraging because they include the more able children in terms of their language and cognitive development, perhaps children with kind of less severe symptom manifestations. But we need to recognize that diversity among the older people with autism that we know likely has implications for what we might expect to see early in life. And this whole line of research has been incredibly humbling. I think a lot of us went into this field thinking, well, if we just look for the right things and we just pay careful attention enough, we're going to be diagnosing all children by the time they're 12 or 15 months. And in fact, often what we're seeing is that the children that are seared into our memory are the children who have these sort of dramatic presentations really early in life. But of course, as one follows these high-risk infants, one recognizes there's lots of children with autism that are sort of flying under our radar as well. And in a way, the bigger challenge is making sure that we're picking up on children across the full range of the spectrum, rather than just sort of playing this, kind of have this effort to see who can identify a case of autism at the earliest age. Well, I can diagnose at 15 months. Well, I can diagnose at 12 months. But we're missing like a large proportion of those children if we get really stuck on just identifying the earliest possible signs. We're recognizing that genetics and genomics now play a very central role, but we also are, again, sort of humble that there's a lot that we don't know about the causes of autism. And certainly research, back to the early twin studies suggests that, if the concordance among identical twins is less than 100%, there's probably more going on. And just in speaking to David Emerald earlier today, I think an important shift in the field is that people with sort of different ideas and different hypotheses about the causes of autism are welcome at the table now. And there's a very healthy respect for kind of different models of autism and a recognition that the complexity that we see clinically probably translates ideologically as well. And it's hard, and it's unlikely that there are children with just, that the majority of children have purely genetic or purely environmental. It's probably a complex kind of variation in factors, and it probably differs between child and child. We also recognize now that early intervention markedly improves outcomes, and I think there's a lot of exciting work, again, a very substantial amount of it occurring at the Mind Institute, thinking about ways of intervening early enough to actually sort of change the course, to perhaps even prevent some of the disability that might be associated with autism. I think we also have to take stock of why we do this research. And the reality is, when one speaks to parents, we're sort of meeting them where they've been for years in recognizing the early signs in the first year, the first 18 months. But when one hears the stories of these parents, often they've been to a number of so-called professionals. They've been reassured, he's a boy, he's your first, why don't we sort of wait and see? And invariably there's been this extended period of time where parents are trying to get someone to listen, and even sort of seeing multiple specialists before the children are diagnosed. And although I think anecdotally, clinical programs are seeing more and more children being referred at 18 months or 2 years, and more early diagnoses are being made, the reality is that the median age of diagnosis, as I'll review in a moment, remains kind of around the age of 3.5 or 4. So there are still lots of children that are missing out entirely on preschool intervention, and we have a long way to go. And the reality is that this research is really all about a respectful and compassionate response to the concerns that parents have had for years, and starting to close the gap between when parents become aware of these early differences and when the children are actually diagnosed. Clearly, the motivation. AJ actually asked me earlier today, what's one of the most, what's sort of the important next step for this field? And I think sort of the first reaction is the advancing the science and incorporating, for instance, biological measures into sort of early detection, because that's one of the real advantages of being able to do prospective research with infants at risk, that we're actually sort of working with real live kids that we can learn from and offer something to directly. But clearly there are some really important clinical issues that we need to push forward. One is intervention, because there's a lot at stake for these families. And another unique advantage of working with at-risk infants, rather than just looking back through home video or asking parents to talk about their kids, is that there's a real live infant and a real live family who are grappling with these concerns, and one can offer meaningful intervention. And again, Sally Rogers in particular, and the Mind Institute group in general, has really led the field in sort of helping us think about what we can offer that's meaningful for these families. I think another really important thing we need to work on is just how are we going to translate all of this into clinical practice? I have to say that there's a lot of the uptake of autism screening into family physician and pediatrician's office has been pretty modest. There's still a lot of pushback, sort of the notion of sort of incorporating sort of formal early detection strategies into healthcare. Physicians are concerned about the false positive. They're concerned they don't have anywhere to send the kids once they identify them. There's a long way we need to go in terms of sort of bridging what we're learning sort of in our research labs to what's actually happening in community practice. And as we're learning about what children with autism look like at 12 months or 15 months, physicians are still struggling with identifying signs in some 3- and 4-year-olds. So, we'll talk about early signs, but I'll try to put it into the context of sort of the health system, and sort of, because we really do need to have a multi-pronged approach if we're going to accomplish the goal of earlier diagnosis for children across the spectrum. So where are we at? Is getting children into effective and syndrome-specific interventions to actually change their outcomes. And then there is sort of the not-so-minor issue of the fact that autism can recur in a family, and families can be informed, if only to sort of pay that much more attention to the development of their younger children to provide support at an earlier stage. So as I mentioned, I think we have to be quite modest about the progress that we've made around age of diagnosis. And although some studies, particularly in the UK, suggest that the age has sort of drifted down somewhat, and again, anecdotally, the sense is that we're seeing more and more younger children. I mean, data from that was published as recently as a few years ago from children born in 2002, the median age of diagnosis across the CDC, Autism Developmental Disabilities Monitoring Network, was between 4 and 5 years old. And that's very sobering. There is, coming from Canada, I mean, there's sort of relatively limited research done in that area. One of the important studies is something that Eric von Bahn, who's a guest at the Mind right now, has been working on. It's a national longitudinal study of autism where children are being recruited at the point of diagnosis in several cities across Canada. And the bottom line is our average age of diagnosis is very similar to what we see in the States. We're finding median rates of a median age of about 3.5, but that's in a study that only children under the age of 5 at the time of diagnosis are recruited. So if one considers the subgroup who are probably going to be diagnosed past the age of 5, we're probably at that 4 to 5 point that many US centers are at. I'll tell you a little bit about a study that we've recently completed in Alberta, kind of a very crude study in a way, where we linked pregnancy and birth records to diagnostic reports, at least based on physician billing records. We identified sort of a prevalence of roughly 5 in 1,000, which, to be honest, probably suggests that we're under-identifying based on that strategy. But most importantly, although we've improved in terms of our age of first identification, our starting point was pretty dismal. And again, as recently